Okay, thank you very much. It's good to be here today with everybody. And I will be presenting an overview of this presentation entitled Responses to the SARS-CoV-2 Vaccines in Patients with MDS and AML. This is also being presented as Abstract 217 in an oral session by Dr. Jane in just a little while. So I encourage people to go there for more details. So these are my disclosures. So as a bit of background, we know that patients with myeloid malignancies, including AML and MDS, based on evolving data, including some of which you've just heard about, are at high risk of severe COVID infection and death. We also know that patients with AML and MDS frequently have qualitative and or quantitative deficiencies of the white blood cells, including the neutrophils and sometimes the lymphocytes as well, as a result of either the disease itself or the treatment of the disease. And it's unclear whether these deficiencies would result in poor immune response to the COVID-19 vaccine, and to date there has been very little reported on vaccine efficacy amongst patients with AML and MDS. So the primary aim of this analysis was to describe the humoral immune response and safety profile to the mRNA 1273 vaccine amongst patients with AML and MDS. So we had previously undertaken a large single-site observational study prospectively of the mRNA 1273 Moderna vaccine in all cancer patients between January 12th and 25th of this past year. And we included patients with AML and MDS, obviously, within the context of this large observational cancer patient study. Blood specimens were collected prior to the first and the second vaccine doses, and then again at about 4 weeks after the second vaccine dose for antibody analyses. We did a retrospective chart review of all cases to collect information about patient characteristics, treatments received, cancer diagnoses, disease status, and other factors. And then to evaluate the antibody responses, it looks like these slides are jumping ahead of me here. To evaluate the antibody responses, a two-step ELISA was performed to measure the IgG response against the COVID spike protein. So shown here are the patient characteristics. And as you can see, the median age was 68. We had a total of 46 patients with AML or MDS, including 30 with AML, 16 with MDS. Median age 68, as I mentioned. The vast majority of patients were white, and the median time from diagnosis to vaccination was approximately 2 years. And shown here are the seropositive conversion rates following the first and the second vaccine doses, broken down by cancer treatment type and cancer patient type. What I'll point your attention to is the fact that there was a 96% overall seroconversion rate after the second dose of the vaccine, about 70% after the first dose of the vaccine. Because of the high number of patients who converted, there was really no correlation between most clinical factors and the likelihood of seroconversion after the second dose of the vaccine. And this included being on active therapy at the time of the vaccination and the lymphocyte count and the neutrophil count as well. So I've summarized here the response to the vaccine, again, amongst this AML and MDS patient cohort. About 70% of the patients were seropositive at day 29 after the first vaccine dose, and virtually everybody, 96%, were positive at day 57, which was after the second vaccine dose. Patient seroconversion rate was not affected, as you might expect, because of the high conversion rate by any factor that we could really hone in on, including age, disease status, time to vaccination, number of lines of prior therapy, etc. I will point out that in the patients who did not respond to the first vaccine dose, there were suggestions of patients that had either been on steroid therapy or immunosuppression as potential contributing factors to not converting after the first dose. Although, again, everybody converted just about after the second dose. The antibody levels themselves were significantly higher after the second vaccine dose than after the first vaccine dose, which I guess is not too surprising. And this difference between antibody titer levels between the first and the second dose was observed in both AML and MDS, and was really observed across all the different variables and patient subsets that we looked at. And you'll hear more data about that at the oral presentation in a little while. Adverse events were common and very much expected and typically mild. These included injection site pain, fatigue, headaches, arm swelling, and other common vaccine-related events. So in conclusion, in this observational study, the majority of patients with AML and MDS converted to antibody positivity after 2 doses of the vaccine. Most variables, laboratory and clinical, did not affect the antibody positivity rate after the second dose, given the fact that almost everybody converted. Antibody levels increased dramatically following the second vaccine dose, which indicated the potential utility of serial vaccination with good efficacy in poorly responsive patients after the first vaccine dose. And while these findings should be substantiated in a larger and more diverse cohort, of course, the mRNA-1273 SARS-CoV-2 vaccine appears, at least preliminarily, to induce a strong antibody response in a population of patients with AML and MDS. And I believe indicates that we should be aggressive about vaccinating such patients. And finally, assessments of clinical response and cellular immune response, which is another important component of the overall immune response itself, the cellular response, are ongoing at this time. So with that, thank you for your attention.